por venir. Hoy día tenemos un invitado muy especial, como ustedes saben. George Prigatano nos está acompañando esta semana en las actividades del precongreso. Y la idea es, de alguna manera, comenzar hoy día con un conversatorio, que es una instancia súper informal para hacerle algunas preguntas respecto a él, a su carrera, a cómo llegó a hacer lo que hace. De alguna manera como preparando las actividades que vamos a seguir desarrollando, como la de la tarde, que es una actividad de discutir dos textos que son más específicos, y el congreso que viene. Entonces la idea es aprovecharlo lo más que pueda. Como es un conversatorio, yo tengo algunas preguntas preparadas para que George comente, pero la idea de pasar una hojita es porque eventualmente, en un momento, si alguno tiene una pregunta específica, anótenla y se la hacen. ¿Ya? Eso. Entonces vamos a parar en un momento y ojalá que tengamos preguntas. So I'm just explaining that we're trying to make the best out of the time that you are spending here with us. Most of the people here are people doing in the internship. Okay, so they are psychologists trying to learn, the basics of clinical neuropsychology. We have a couple of OTs as well that are part of our team. We have some guests that are also interested in the topic. Alberto C. Molina, que está ahí adelante, es nuestro otro invitado de España, a quien vamos a tener el placer de escucharlo el miércoles. Eso. Así que, ok, y vamos a hablar, o sea, va a ser en inglés. Si alguien tiene alguna, se le arranca algo, puede levantar la mano. ¿Está bien, les parece? Ok. So I have some questions for you, tough questions.
All right.
So the first question I have for you is that if you can tell us about the history behind your encounter with neuropsychology and working with neurological patients or brain injury patients. How did you come about doing what you do?
Okay. Well, there's a long version of the story and there's a short version of the story. I'll give you the intermediate version of the story. When I was an undergraduate, I went to Loyola University in Los Angeles, a Jesuit university, and everybody had a minor in philosophy. It didn't matter what your subject was, everybody philosophy minor. And I really loved philosophy, but I couldn't get a job in the philosophy department. It didn't pay very much money. So I became interested in psychology, but I was really interested in philosophical questions as much as I was interested in psychology, to be very frank. And so as I developed and read more and more about psychology, there was a guy named Carl Rogers who wrote about client-centered therapy. And I was very taken by his philosophical approach to helping people psychologically. And so I decided to get a PhD in clinical psychology. But at the time I was in my master's degree program, I met some people who were consultants to industry, and they were helping select executives to do different jobs. And I was always interested in work, who's successful in work, who can accomplish things. And so I thought, I'm going to get a joint PhD. I'm going to get a PhD in clinical psychology and industrial psychology. So I went to a place where they could give you a joint PhD. It was in Ohio, Bowling Green State University. And when I got there, I got very bored with industrial psychology. It was putting me to sleep. It was like, oh, this is silly. But then I had a friend who said, you ought to look at physiological psychology. And so as a clinical psychologist, I became interested in galvanic skin response and heart rate. And so I did my dissertation in psychophysiology. So I got interested in the biological side of psychology. And then when it came to my internship year, I went to Oklahoma. And the reason I went to Oklahoma is that I'm from California. I was going to school in Ohio. Halfway back to Oklahoma, California was Oklahoma. So I said, I'll go to Oklahoma. And there they had a rotation in neuropsychology. That's how I became interested in it. And so I took the rotation in neuropsychology from a man named Oscar Parsons. He's not real well known, but he was a very influential neuropsychologist at that time. And the story's going to get a little bit longer. When I was there, he introduced me to a neurosurgeon. And the surgeon's name was Dr. Barton Carl. And I was learning about tests and how to give tests. But at the same time, Barton Carl's secretary had a traumatic brain injury. And they said, George, can you do something to help this young man? So I'm learning all of these tests, but I want to help this young man. And you know, the tests don't tell you how to help the young man. So I began looking at what can neuropsychology really do to help in the recovery of a brain injured person. So that's how I got into the field, by taking a course in neuropsychology based on my interest in psychophysiology, and then an actual patient. And the patient, he was aphasic, and he wanted to be a librarian. I can imagine, you're aphasic, and you want to work in a library. It seemed very difficult, but that's what his passion was, to do that. So I would take him to the library at the medical school, and we'd figure out, how could you sort books? What could you use? And as we were working with him, Kristen, you'll enjoy this, one day he told me he had a dream. I said, what were you dreaming about? He said, I was dreaming that I was crying, but only out of the left eye, the symbolism. And I said, why do you think only out of the left eye? He said, because they told me I have a left-sided brain injury, and that's why I can't work in the library. And it hit me that neuropsychology was fascinating, but it was limited. You had to have a much broader view of human beings in order to take what you know about the brain and apply it to helping patients. And once he started to talk to me about crying out of the left eye, then we talked about his anger, his depression, and then things evolved.
So with that case, you realized that you needed like a broader way of looking at patients.
Absolutely.
So in a way that connects with my second question, which is that in terms of rehabilitation, what would you say have been your main influences? I mean, like in terms of people or ideas that could say that they set the scene of the way that you work, or the way that you see rehabilitation?
Well, because I had worked with that young man, I was interested, what could you do to help people in terms of getting them back to work, which I had an interest in, getting them back to work particularly. And at the time, in brain injury rehabilitation, it was all focused on physical activities, walking better, talking better, being more mobile. There was really no discussion of dealing with the cognitive difficulties at that time. And to deal with their emotional side, well, they didn't want to do that. They gave them medicines rather than dealing with the emotional reactions. And so, again, there's a little bit of a longer story to this, but I'll give you the shorter version. After I was in Oklahoma for a while, I went to Stanford University, and I worked with a man named Carl Prigatano. And I was very interested in how is emotion and memory connected in the brain. That was a very early question that was in my mind. And when I worked with Prigatano, he made me think about things in quite a different way. And in about 1980, there began to be some conferences in the United States on cognitive rehabilitation. These actually occurred in Indiana. And I had just come from Prigatano, and I was invited to give a talk at this conference in Indiana. And all of the work was on cognition, memory compensation, attention problems, visual spatial disturbance. And I listened to that. I said, the patients I work with, they're not worried about that. They're worried about their emotions. They're angry, they're irritable, they're depressed. Why aren't we discussing this in the rehabilitation? So if I've had any impact, I think it's been to say neuropsychological rehabilitation is as much interested in the emotional and the motivational characteristics of the person as is in their cognitive deficits. So I think my work is trying to push the spectrum to say, you're not dealing with the real person unless you include this component to the rehabilitation.
Do you think that, looking backwards, that situation has changed? That emotion has a more recognized place? And
I do.
yeah?
Yeah, I do. I think different places it will emphasize it differentially, you know. But there is much more written about adjustment and quality of life in brain injury rehabilitation. I think that's where you see the end product.
Adjustment and quality of life.
That's right. Because in the old days it was how many feet can you walk? How much range of motion do you have in terms of arm or leg? And now, even in medicine as a whole, there's a push toward, if we're limited in what we can accomplish, then how does what we do impact their existence, the quality of their existence? And I think that's where you see the emphasis the most. This is getting a little ahead of it, but part of that hit me was that patients were not always aware of the extent of their cognitive difficulties. And the other thing that we did do, I think, is emphasize that awareness is a very important component to neuropsychological rehabilitation. And I think that was the other impact that we've had. And I think there's a lot of studies that have tried to look at changes in awareness, rehabilitation process, rehabilitation outcome. So I think those are the two areas that we've had some impact on.
So in a way you see a connection between the increased interest in awareness as a key concept in rehab, but how that is connected to emotion.
Exactly.
There is something there that evolved.
That's
is
right.
That what you're saying?
I'm saying that they're interconnected because this goes back to my philosophy side. Consciousness is not a purely cognitive function. Consciousness is the integration of thinking and feeling. It's only when these things come together you go, I'm aware. You know, when you solve a problem and you suddenly have insight, you have emotion with that. It comes automatically. You don't have to ask for the emotion. It's right there. Okay? So, disturbances of awareness always produce some disturbance in emotion. Disturbances in awareness always produce some disturbance in emotion. And it's different when it's organic, when the brain is damaged, versus when it's psychiatric. It's a very interesting thing, and it makes psychology really alive. If you understand these phenomena and you work with patients, then you see the great interconnection between these two areas. And I think, again, I think that people have been recognizing that there is an importance here in these two topics.
And is this interconnection between emotion and awareness what brought you close to psychoanalysis?
That's another interesting thing about what brought me close to psychoanalysis. When I was being trained, it was all behavior. B.F. Skinner was alive. I saw him in a number of talks. And Carl Rogers was the other theorist, and they used to debate, you know, and I used to watch the debates. And they were both highly intelligent, very smart people. And nobody could argue that the principles of learning are unimportant. They're very important, and they're very important in certain aspects of brain rehabilitation. But Skinner had too reductionistic of a view. Too reductionistic of a view. And Rogers had a very kind of philosophical view of how it. So I was struggling in my early career about, am I going to be a client-centered therapist? Am I a behavioral therapist? But how I got interested in psychoanalysis, I did my internship at the University of Oklahoma. And there were 3 psychoanalysts that supervised me when my training. 2 were psychiatrists. 1 was a lay analyst from Tavistock Clinic in London. C.V. Ramana was his name. He was a lay analyst. And when I would go to the psychiatric clinic, the problems people were talking about were not the problems that Skinner was talking about, and they were not the problems that Carl Rogers was talking about. They were talking about addictions. They were talking about sexual problems. They were talking about aggressive problems. They were talking about marital problems. They were talking about really real problems. Who talked about the real problems? Sigmund Freud and Carl Jung. So my interest in psychoanalysis came by listening to what patients were struggling with. And the addictions, the sexual problems, the aggressive problems, getting arrested, going to jail, those are the real problems. And so nobody convinced me to become interested in psychoanalysis. I came from quite a different background, but when I started to see what patients were struggling with, I thought, oh, they're not fully aware of what's going on. And the issues of sex and aggression that Freud talked about, and the role of symbolism and meaning and culture and religion in influencing people, Carl Jung talked about. And it was these ideas that I found myself gravitating to when I was working with brain injury patients.
And how would you say that the neuropsychological rehabilitation community took, this psychodynamic angle to rehab? Because, in my opinion, it's always been there, but there is some sort of ambivalence,
there's a lot of
in professionals. And, I mean, what is your feeling, with that, and how have you managed to, in a way, persuade clinicians and colleagues to consider that point of view?
I'm not sure I persuaded very many, to be honest. But I'll tell you a true story. Barbara Wilson is very well known. Barbara Wilson visited our rehabilitation in Oklahoma many years ago. And when she finished, she says, if I had a brain injury, I want to come to this rehabilitation program. Barbara doesn't always like what I have to say. This is going to be on a tape, but we politely disagree about different things. But the proof, they say, have a phrase in the United States, the proof is in the pudding. What do you want for you if you have an injury to the brain? You want somebody to just work on your attention, teach you memory compensation, or do you want somebody to talk to you as a human being? And that's where bringing multiple views about what makes us human and what we struggle with needs to be a part of the rehabilitation program. So I don't think there is much, in the scientific journals, much discussion of what we talk about, but I think in the actual care of patients, many people recognize that this is an important component to the rehabilitation. I think one of the questions that came up many, many years ago is, how do you know if psychotherapy works with brain injury patients? What's the evidence? It's a legitimate question. What's the evidence? And I always said early, and I say it today, if you take a rehabilitation program that doesn't include understanding the psychological makeup, the psychodynamics, but does everything else, physical therapy and so on, when you take a program that does, you should compare the long-term statistics of these two programs. Because if what I'm saying has value, the program that deals with the psychotherapeutic issues, those patients should be more productive and have greater long-term interpersonal relationships than the other patients. I think that's how you know. You never know directly, you only know indirectly whether or not it's making a difference.
It's funny what you mentioned about Barbara, because one of my questions was that there was an historical debate between you and her. And it was quite a popular debate, like in the 90s.
Yes, that's right.
I've heard about it. I wasn't there. And I think that you two were discussing, whether these ideas were useful, how to operationalize them. And even people nowadays remember that debate.
It still goes on. The debate hasn't stopped. I have great respect for Barbara Wilson. She's an occupational therapist by training and then became a behaviorally oriented psychologist because of the influence of behaviorism in England. Hans Eysenck was the chairman of psychology at the University of London and the Institute of Psychiatry. Very powerful critique of Freudian's work, and he had some good points when he said there's some things that have to be reckoned with. But came from a very behavioral perspective, and I had recognized the limits of behaviorism, the limits of it. It's valuable, but it's limited. And in the debate, I would say you must understand the phenomenological experience of the patient. What do they actually experience? Not just what is their behavior. And when I give the lecture on Thursday, I will show you can change behavior but not experience. And so, what are we doing here? We're just changing behavior? Why not teach monkeys to do fun things? We're human beings. We have evolved a little higher than the monkeys. And so behavior is important, but it's not enough for the human condition. It's not enough. You must understand what the person struggles with and what you do to reestablish vitality in them and resiliency to deal with life's problems. That's really what rehabilitation is. You build resiliency. this is bad has happened to me, this is bad has happened to me. Do I give up, or do I reconstruct? And again, Carl Jung was very, very insightful about these issues. And most people think Carl Jung was psychotic or out of the nuts, but sometimes the psychotic ones are the smartest ones.
Yeah.
Okay? But he talks about these meaningful things, and Barbara and I would clash over that. They say, well, is that all that important? Let's teach them a memory compensation technique, or let's be more practical in the interventions. And I think that's a necessary but not adequate. It's not sufficient in itself.
What you're saying is something that with our team we struggle, on a daily basis, which is that sometimes we know that a specific patient can benefit from a specific compensation technique.
Yes.
But over and over we realize that there is something which is emotional, we would call it resistance, that sometimes people that are not ready to use a compensation strategy. So something that looks, as quite easy, to implement, it doesn't turn that way. And I think the emotional side, identity, has a role there.
You hit on a very important topic. And this is one of the differences, I think, between some of the things we've talked about and other people. You have a patient that you know has a memory problem, and you know that teaching them memory compensation would help them, but they're resistant. Why are they resistant? Why are they resistant? I say to people that I work with and students, if right now somebody knocked on the door and says downstairs they're giving away $100 bills free, should we continue to listen to me talk, or should we go down and get our $100 bills? I think all of you would say, it's nice to hear you today, Dr. Prigatano, but we'll be back right back. You'd go down and get your $100 bill, and then you'd come back up. Because you see it is in your best interest. You can read what I've written about. But the $100 bill is sitting downstairs. So if you see the value of something, you will go for it. It's not resistance per se, it's they don't recognize the value of what you're trying to teach them. If for some it's an emotional factor, for some it's a cognitive factor, for some it's a combination, but you must enter the phenomenological field of the patient. You must understand, why is there an unwillingness to do this? Why do they not see it in their best interest? That's why you're a psychologist before being neuropsychologist. Neuropsychologist is an add-on. I always say to our students, you're a psychologist first. Then you can be a neuro, a clinical, an experimental, it doesn't matter. But for psychology, you should understand the experience of the person. What do they actually experience? And why did they choose not to do something that you think would help them?
But why do you think it's so difficult to consider that very basic idea of entering the phenomenological field of patients? Because, it sounds so sensible, but I think that rehabilitation professionals, they struggle with that. Do you have any ideas why it's a challenge?
Yes, I do. I mentioned that I've heard Skinner talk and I heard Carl Rogers talk. In 1972, I got my PhD in clinical psychology. And the American Psychological Association had their convention in Honolulu, Hawaii. I had never been to Honolulu. So I went there to meet Carl Rogers. And there was Roger Sperry, the Nobel Prize winner who did the famous split brain research, and Carl Rogers there. And I went up and I shook their hands. I wanted to meet them. And when I met Carl Rogers, I shook his hand and I said, I've read everything you've written. I've just got my degree in clinical psychology. I'm really excited. And he said to me, I hope it doesn't take you too long to get over it. I said, what do you mean? I worked so hard to get my PhD in clinical psychology. He said, the scientific attitude will take you only so far in helping patients. So we are trained to be scientists, we are trained to be objective, we are trained to be observers, to be there for the patient, but to maintain a professional distance. Right? Right? Otherwise we get sloppy. We treat them like our brother or sister, and that's not necessarily good, right? Well, I think there's a happy medium. I think you have to have your professional standards and know what the ethics are of what you can and cannot do with a patient. Ethics are extremely important for our field of psychology. Very, very important. But you can't be so rigid that you don't listen to the patient. You don't talk to the patient and find ways in which the patient can talk to you. Music, artwork, stories, fairy tales. These will let you enter the phenomenological field of the patient more than anything. I'll tell you just a little story. I just finished a book, and one of the stories in the book is there was a child, I want to say maybe she was 12, and she had a meningioma in the right frontal area of the brain, and she did have some cognitive difficulties, but she was a very bright young girl. And so I examined her, but she was getting bored with the tests, and I always laugh. You know, I get bored with the tests too. I mean, there's more to life than testing, you know? And so, anyways, we're working, and I can see she's getting bored. So she says, this goes back to your question. I know I'm getting off topic a little bit. So we're sitting there, and on my bookshelf, I have a book of fairy tales. And there's so she gets interested. I said, you want to take a break from testing? She says, yeah, I want to take a break from testing. So we take the book down, and she opens up the book, the fairy tale, Ugly Duckling. I don't know if you know what this fairy tale is. It's an old British fairy tale. And I won't go through the whole story, but she says, I feel like an ugly duckling. The psychological test will never tell you she feels like an ugly duckling. And we talk about what that means. She then becomes enthusiastic. Let's go back to the test, because she's now talking about something real to her, how she actually feels after this brain injury. The mother comes in. She says, how did it go today, honey? Oh, it's fine. Let me show you this book about the ugly duckling. The mother is a very beautiful woman, very tall. And she says, I feel like an ugly duckling too. I think, how could she feel like an ugly duckling? She says, I'm way too tall. I feel like all the men are too short for me. Okay? I feel like an ugly duckling. And so, Christian, it's looking at other ways to enter the phenomenological field. You just don't talk to people. If I get to know you, maybe after a long period of time, and every psychotherapist knows this, after a long period of time, they'll tell you what's really important. They'll never sit down and tell you what's really important to me. It's too private. But if you look at the stories, the movies, the songs the patients like, they will reveal really what they experience. And then you connect. Then you enter the phenomenological field. And then you have to treat it with respect, so that you're not, it's so private that you can't just quickly communicate it to everybody else. You must remain, this is where the confidentiality becomes very important. But once the patient knows you know what they're experiencing, they're not alone with the problem. Once they know you know, and now, as I say, you're off to the races. Now you have something to work with, no matter how impaired the patient is.
Perhaps this is related to this conversation we're having about entering the phenomenological field. You made me think about your is it 12 principles?
13.
13, sorry. 13 principles. Is it 1991?
The book?
Yeah.
It was published in 1999.
99, yeah. You know, I was wondering when I thought about your work, what made you write 13 principles? I mean, it's kind of a funny thing to do, like to say in a book, okay, we need to guide our everyday job by 13 principles. I'm curious about the context that explains, why you came about doing that.
Okay. Well, it's again an interesting story. For me, it's interesting. Again, a little background. I was at the University of Oklahoma, and I was in an academic job. I was an associate professor, and then I had a chance to go to Stanford, but the university wouldn't let me go. They said, you don't have enough, you just got tenure, and you can't go. I go back to my friend Barton Carl. I was torn. I said, I want to go to Stanford, but I have this academic job with tenure. And he said, come over to my house and have a scotch. He was a cowboy. He was a cowboy, or a surgeon. So we had a drink. And he said, George, tell him to go to hell. I said, tell him to go to hell. I said, you think? He says, if you're worth anything, you can get another job. So I resigned my academic job. And I went to Stanford, and I came back and developed this rehabilitation program. And I worked very intensively for about 5 years in the program, and I learned a tremendous amount. And then I was invited to go to the Barrow Neurologic Institute to begin a rehabilitation program like this. But I wanted to develop a larger department. So I started the rehab program, and then I began a department of clinical neuropsychology. With time, my colleague, Pamela Klonoff, who was my first student, my first resident in neuropsychology, she became the director of that program, and I stopped working in rehabilitation. I became more involved in administration, research, assessment, and psychotherapy. But as I got out of the field, I said, I want to put closure to what I did in terms of this work. So I want to write about the principles, because this is what I felt like I've learned from doing this. So that's why I wrote it, in terms of I've stopped doing that work on a day in and day out basis. But the ideas that emanated from that work, I wanted to put on paper. I wanted to see, and it gets into another interesting statement, that when we make exterior what we feel inside, it gives us a sense of understanding. One of the values of writing and doing research, it clarifies your thinking. It's not just a publishing paper. You think better when you put it on paper and somebody says, what do you mean by this, or this is unclear, or what have you. So I wrote the book to summarize. Now, why did 13 principles come? I don't know. I know that as I was writing it, this made sense. This made sense. This made sense. It could have been 23, it could have been 5. 13 came from my unconscious and my what struck me as important issues in the care of patients.
Would you change
No.
any of them? Would you add, take one of them out? You know?
No, I think I would keep them the way they was. I think some have become more important to me. I think the first principle has remained the most important for me. Entering the patient's phenomenological field and reducing the frustration of the patient. Most patients are more confused in their thinking than we ever can appreciate. And they are frustrated because of their confusion. So neuropsychologists must enter the phenomenological field with the patient, sense what is upsetting or confusing to them, and do what they can to reduce the frustration, not add to it. So one thing I talk about, one of the principles about psychotherapy is that you just don't sign a patient up for psychotherapy. You don't go to a rehab program and say, oh, you're going to see the psychologist Monday for psychotherapy. No. It's not the way it's done. Some patients can benefit from it, some may not. You have to understand when to initiate it, when not to. Get a little off the topic, I would say to students, psychotherapy is like delivering babies. You have to know nature and what's evolving. But timing is everything. You don't say to the mother, you've got to have the baby now because I have to go on a trip. You have to see when she dilates and when she's ready to have the baby. And in psychotherapy, you have to wait and see when is the patient ready to discuss this. You don't force it. So I've become the phenomenological and reducing the frustration, knowing the timing of psychotherapy. The principle about awareness and understanding how important it is in the process and outcome of rehabilitation. And then the last one, the role of symbolism. I find I would never change those. I've become more and more convinced that those are the valuable ones.
I was thinking that what I really appreciate about your principle is specifically that you use the concept principle. And in a way, I interpret that as in contrast to what you could see in everyday practice, like in modern neuropsychology, where I would say there is this tendency of manualize everything. So for this kind of disorder, you have this and this and that.
Right.
which in a way neglects, people's difference, between one patient and the other. And I have the feeling that by using the concept of principles, what you're saying is that, okay, there is something very basic you need to consider. Now, the way that you apply it, that's
right.
a different matter.
That's right.
So, I don't know if you have that in mind, when you, I think it gives you freedom and also respects, like heterogeneity in the clinical population. But for some people, it's a bit, it produces anxiety because it doesn't tell you what to do.
Well, I'm very happy you interpreted it that way, because that's the way I intended it.
Is that what you meant? Okay, I read it right.
And I've often say, patients will say to me, or many therapists, well, what am I supposed to do next? What you're supposed to do next is understand what you're looking at. If you understand what you're looking at, something will come to mind. But if you don't understand what you're looking at, it's silly to say, do this, do this, do this. It reduces anxiety if somebody tells you do these 5 things. But it doesn't really help you develop as a psychologist, nor does it help you really help the patient. And so, and it also goes into a philosophy. As I said, I was interested mainly in philosophy when I studied law. Carl Jung talked about the individuality of people. We are all individuals. We share common features, but we are individuals. We're different. And he would say, I love the example. He says, some of us are oak trees, some of us are palm trees, some of us are bamboo shoots. There's such great variety of who we are. But be true to who you are. If you're an oak tree and you want to be a palm tree, you're in big trouble. But, so, understanding the individuality of the patient becomes very, very important. And the principles are to guide, to say that you need to keep this in mind when you're working with patients. But your own clinical experience, your own personality, what you find meaningful, has to be the guiding force in terms of interacting with the patient.
You told me, I think yesterday, that part of your job is to supervise and train kind of new clinical psychologists that they are entering into neuropsychology, right? I wanted to ask you, because we are trying to do that here as well, what has been your experience in training young people? What do you think are the challenges? How come the way that you teach things to them is different than the mainstream training? Do you have any thoughts on training?
I do. I've got, my mind sometimes goes in 2 different directions at one time. So I'm going to go in one direction and we come back to the other direction. I mentioned Carl Prigatano. He was my teacher. And he took my brain and he made me think about things. And he said to me, in science, we simply collect facts. But he says, true knowledge comes when we resolve paradox. This is true and this is true, but they seem opposing. How could they both be true? When you can understand why they're both true, then you know something. Okay? So the ability to always understand conflictual ideas, conflictual views is a very important thing. And he would say to me, when I was at Stanford, there's the library. Over there, and we have something interesting to say, come back and see me. That was his training in many ways. And I love that training, because it gave freedom to read whatever you want to read, come and ask whatever questions you have, but think about where are there opposing ideas that seem both to be true that cannot fit. That's the spirit of my education with students. But I see many of my colleagues who I have great respect for, and I don't mean in any way to say that what they're doing is not valuable, but there's such a biological focus now. What does the neurotransmitter dopamine do? What are the interconnections of the several pathways between frontal and parietal area? This is interesting, but they are making psychologists mini neurologists. You have to be a psychologist, of which you then take this beautiful knowledge emanating from the neuroscience. And it is beautiful knowledge. It's fascinating knowledge. One of the true gifts you will have if you're a neuropsychologist, you'll never get bored. Because it is always evolving. so many interesting things, okay? But you have to go beyond the biology of it. You have to have a broader view. So that's what I try to stimulate in the students. And what I say when we see patients together, as I say, I want you to just simply watch. I don't want you to do anything. I'm going to tell the patient and his family, and I always interview the patient and family together the first time, because I learn a lot by seeing how they interact. And I say to the resident, just sit next to me and just listen. And then when it's over, I say to the resident, what did you observe? What did you see? What did you hear? Because what you want to instill in students is the ability to clinically observe, to watch what is seen, what do I evolve, not just to measure, but to see what did you observe, you see? And then from that, the dialogue. Then it comes to the questions of what would you expect in the early stages of a dementia? What would you expect in the recovery process after a traumatic brain injury? What would you expect with a malignant brain tumor in the frontal or parietal lobes? If it's a glioma versus an astrocytoma, what would you expect? So that the medical neuroscience knowledge is important, but it's always interacting with the psychological exchange. And it's a slow process, but I find students respond to it because it hits the core of why they want to be a psychologist. Yeah.
My last question, so we can open the questions to the floor, is, I mean, you have traveled around the world, you have visited many countries, you have collaborations with labs and rehab places in Europe, in the States, South America and Brazil.
Yeah.
So I think that perhaps you have a feeling of the state of the art in rehab and neuropsychological rehabilitation. Here in Chile, we are a developing country, and neuropsychology is just being born and as a field. So, have you had any kind of learnings, by getting in touch with these labs and rehab places regarding how you could, in a way, develop the field in under-resourced settings?
A little water. Let me just be clear on what you're asking me, Kristen. You're saying, based on what I've experienced in different parts of the world, what knowledge, what insights could be applied to?
No, I'm thinking about what would be key or relevant, for places that are beginning to develop a service, for example, or to develop the field of clinical neuropsychology. Do you have any advice? What would be important to consider or keep in mind?
The field of clinical neuropsychology or the application to rehabilitation?
Maybe both.
Well, I'm biased in this. I am biased, I must tell you. So that's my disclaimer. I'm warning you, I'm biased. I think clinical neuropsychologists should be very good clinical psychologists first. Many people don't believe that. They say, no, neuropsychology is a specialty all of its own. You're interested in brain-behavior relationships. I'd say you're interested in people who have brain injury, who you understand the relationship between their brain injury and their behavior or their cognitive function. So my own opinion is that you would train very good clinical psychologists first. And that means seeing a lot of normal people, a lot of people with psychiatric disorders, and then you see people with brain disorders. And you start to say, how are they same, how are they different? How are all these three groups the same and different? I also believe you should have a developmental approach. I think you should see children through people in their 90s to understand the natural plan of the nervous system. I talk about this in a minute. Human nature is not defined at any particular point. It's the gamut. Okay, what is human nature when you're 3? What is human nature when you're 8? What is human nature when you're 22? What is human nature when you're 65, 90, 104? So that's what I would train as a good clinical psychologist, see a lot of normal people, see people with psychiatric disorders, see people with neurological disorders across the lifespan. Say, I'll be 45 before I finish school when this all happens. Neurosurgeons are about 45 when they finish. It takes many years to learn this stuff. Your PhD is your library card. Your PhD allows you to learn. That's what it does. So I would do that. Then after that, I would say for those clinical neuropsychologists that are interested in helping people live with and adjust to and improve after brain injury, then you go to the rehabilitation center. I would see that towards the not the end, but as they evolve their skill base and their interest, you see. And then I think I would instill in them one of the gifts we have as psychologists is we are trained in the scientific method. And while some people find research exciting, some other psychologists find it boring. They say, I just want to see patients, I don't want to do research. Every time I have done a study that is clinically relevant, I learned something I didn't expect to see, and it made me a better clinician. So I think one of the differences for psychologists is to say, what problems interest you? And you don't always have to do immediately a research paper. One of my professors said to me, and it was a very good idea, he said, get a notebook, and when you see something interesting in the patient, write down. Now you get on the iPads and you put it right down. I saw a patient today who hallucinated about their mother, and I found out that this boy was sexually abused by his mother. Write it down, just hold it in your music. I saw a patient who was paranoid today, and I saw this. See what ideas hold your interest. And after a while, you'll start to evolve a clinical research project. Many patients say, many psychologists, I don't have time to do research. You have to do research. It's not a question of time. You will only learn by observing something. And you'll be surprised. I can give you many examples of things that we learned that we never expected. We were not looking for, but it popped out in the midst of the study, and we said, ah. And then you get the real pleasure of the intellectual side of what you do. The emotional pleasure is when you help the patient. When the patient looks at you, and you know that you've helped them. And I'm going to make another editorial comment here. One of the questions that comes up all the time is evidence. Evidence. What's the evidence? You know, if I have an evidence-based therapy, then wonderful. What is the nature of evidence? What exactly is evidence? Is evidence always randomized control studies? No. What is the nature of evidence? This is a very important question. I read, as I was writing my book, I read Erik Erikson's work, and I became very fascinated by his wisdom. And he says, how do you know if you helped a person psychologically? How do you know if you helped them? And of course, we're interested in the behavioral change. But he had a beautiful statement. He said, when I make a statement to the patient, and the patient on their own begins to talk more about what the problem is, and the patient on their own starts to think through, man, how could I deal with this problem better? Then you know your intervention was valuable. Then you know. Because they behave more ownership, more sense of resiliency. I think I can deal with this a little bit better. That's how you know if it works. And when psychologists do this with a patient, that's the pleasure that they get. There's the intellectual pleasure, okay, of understanding the relationship. But when you see that other human being saying, I think I can handle this better. Now I understand why I had this problem. It's a great joy that we have in our field. And that's what I think I like to instill in the development of psychologists.
I have no further questions after that. La idea es, alguien, preguntas abiertas, ya sea en inglés, pueden escribirla en español y las traducimos. ¿Alguien pensó en alguna? ¿Tiene alguna pregunta que quiere hacer? ¿Comentario?
Yo.
¿Sí?
Sí. ¿Me ayudas a traducir? Pero de repente
Sí,
no me
dale.
puedo expresar muy bien porque he make a difference between organic versus psychiatric patients, but we have patients that have injuries that leads them to increase the previous
Psychiatric
psychiatrist borderline traits.
Yes.
So their coping mechanisms or defense mechanisms are very low. So they reject when we are trying to get, or we reach a point where they're increasing their awareness, they defend strongly and they make catastrophic reactions. So we get back to
I think I understand what you're saying.
mm-hmm.
Can I give it back? Go
Yeah.
ahead. No,
In
go
your
ahead.
experience, how do you manage? Because for us, it's very frustrating. We are novel in this field, so this transference is very
Fuerte,
fuerte,
strong.
desgastadora, digamos.
Yeah.
You know, you said several things there that are important, but I'm not quite sure. You're saying that the patient has some adjustment or psychiatric problems before the brain injury, right?
Yeah.
And then you're saying that they didn't have good coping skills or mechanisms of dealing with stress or problems or anxiety in their life. And then you're saying that if you get to the awareness, it increases their resistance and they develop a catastrophic. Is that what you were saying?
If you have some emotional contact with their feelings,
Yeah.
about their self, about their experience of the environment, of their
Okay.
herself, the response is very low.
Okay. I may have to stand up to answer your question. And I know you have a camera on this, so it's going to be, but it sounds silly, but I'm going to have to stand up to answer your question. Because what you're touching on is that you can't always do the type of psychotherapy you do in an office when you have a patient that has brain damage and significant psychiatric problems, and that you start to talk with them and they get upset, okay? So this is a true story. I'm in Phoenix, Arizona. There's a young man, he's about this tall, he's a lot bigger than I am. And he's easily agitated. He paces back and forth. And in one day in the group psychotherapy, somebody says something and he goes wild. He gets upset. So I go up to him and I say, John, and I get close, but I don't get too close to him. I guess, hey, John, I put my hand towards him, but I don't touch him. And I say, John, I understand something has just happened here that has upset you, and we apologize if we have not seen something we did that upset you. What we're going to do right now is we're going to stop the end of the group. I'm going to have my colleague Pam Klonoff continue the group. John, let's you and I go take a walk. And he gets up and we walk. And we go downstairs and he's swearing, son of a... And he's going, he says, John, let's go a little further outside here. And because people are going to think something's going on. And he's pissed. And he's yelling and screaming. And we keep walking and walking and walking, and finally he slows down. And I said, John, and he starts to mutter about how mad he's at his wife because she's divorced him since he had his brain injury. And somebody said something about their wife in the group psychotherapy session, and he couldn't tolerate it. Okay? We didn't know that. But if I said to him in a traditional way, well, let's talk about your feelings, he'd punch me in the nose. You can't always do that. You have to be able to adjust to what that person is able to do at that particular time. And I don't know why I said, let's get up and walk, but I figured that was the best thing at the time. And so you do develop your instincts in terms of how to manage this. So there's an example, right? I didn't attempt to do more interpretation. I didn't attempt to do any contingency or behavior. I said, let's walk and you just tell me what is upsetting you. And we walked and walked and walked. He calmed down. And I said, John, I don't know if this particular program, I said, the group psychotherapy is sometimes agitates you even more. And he said, yes. I said, what do you think would be less agitating? He said, I love working with animals. At the time, this patient was in Phoenix, but before coming to Phoenix, I was in Oklahoma City. And I said, I know of a rehabilitation program in Texas, in San Marcos, Texas, where they have a big ranch. and they work with people to eventually work on the ranch, take care of the animals, and then they slowly move them into more living in small communities or so forth. John, do you think you'd be interested in that program? He said yes. So I didn't just dump him. I got on the phone with the head of the program. I told him about John. And we brought John to San Marcos, Texas. And he continued his rehabilitation there. And he would yell and scream, and they let him go walk out. And when the rattlesnakes came out, he came back in. Okay? It was a very natural form of therapy. Okay? So he had some psychiatric problems, and we did, once we saw what produced the catastrophic reaction, we adjusted our thoughts about what would be the best place for John. And eventually, he was able to interact with the animal, and they have a very calming effect. Because the animals don't talk back, they don't challenge you. They can be very loving to you. And he felt a sense of competency again. He was cleaning some of the horses, he was cleaning some of the goats and so forth. And he eventually was able to work in a community setting, in a small feed store that was a part of the town. So he was able to progress. So this rather long story is going after, you as a psychologist must understand the dynamics. And then you have to use your knowledge base, what fits best for this particular person. Other patients that I have worked with, I might say, okay, so that's fine. Let's talk about this more tomorrow. I could give you another example where a patient got very upset in a group psychotherapy session, and her picture's in the second book, where I said to her, I said, what was upsetting you today? Nothing. She put her head down. Let's talk about, I was doing all the talking. She was doing nothing. So I said to her, it was a Friday, I said, would you do me a favor? If I give you this paper and these colored pencils, would you go home this weekend and draw anger? And she drew the picture. And she had a lot to say. But in the context of this, she said, this is between, I said, I want the staff to understand what's going on between you and me. And I don't want you, she was very angry with one of the therapists who she felt was condescending to her. So sometimes you go more into a psychotherapy discussion, sometimes you take a walk around the block. Okay? But it's your knowledge base that makes those decisions. You see? So anyway, so that's why I said, if you understand normal reactions, you understand what psychiatric, what anxiety, what paranoid ideation is, and so forth, and then you understand what brain injury does, then you are equipped to be spontaneous in a way as to what is most appropriate for that patient. But it's your understanding of the phenomenon. That's always the training is, do you understand the complexity of what you're seeing in a patient?
Yeah, maybe we are trying to focus on and learn cognitive aspects of the functioning of the brain, of the neuropsychology, and then we are collapsed because our patients are their dynamics makes all our assumptions fall down.
It just makes them momentarily immobilized. It makes the assumptions, the understanding is there, but again, how you modify it for the patient is something that you have to learn. And one thing that was very helpful to me with the psychoanalytic training that I had was the realization that I cannot help every patient. That becomes really important. That's not a bad thing. You know, I learned that from the neurosurgeons too. I saw it in the psychoanalytic training, but also my neurosurgeon, the reason I have great respect for neurosurgeons is that the good ones know what problems they can operate on and which ones they better leave alone because they'll make it worse. The really good ones do that. We should be the same way as psychologists. We should say, what kind of patients can I really help and what kind of patients I have no business messing around with because I don't know what the heck I'm going to do for this particular patient. And you learn that as you go along. You start to recognize, I don't have much to offer this patient. I don't mean to sound discouraging. This is an area that Barbara and I would disagree about. She'd say, no, every patient deserves rehabilitation. I say, sure, I agree, every patient deserves rehabilitation. I can't, all I'm saying is I can't help every patient. That's all.
Thanks.
¿Otra pregunta?
Please.
Álvaro. Sí, yo te trabajo.
Algunos pacientes, muchos pacientes que tienen lesiones cerebrales adquiridas tienen como expectativa como el retorno laboral, como parte del éxito, como de la rehabilitación y de la recuperación. Pero estas dificultades en muchas ocasiones son invisibles para los equipos de trabajo.
¿Qué quiere decir en el
O
trabajo?
sea, en el trabajo, para la gente que trabaja. Lo que en muchas ocasiones termina provocando la salida de la persona o no la reincorporación en el ambiente laboral.
Yes.
Y muchas de las expectativas del proceso de rehabilitación están puestas en el retorno laboral.
Okay.
En ese sentido, ¿cuál es el rol que cumple el neuropsicólogo en el proceso de la reinserción laboral y de cómo evitar, cómo generar expectativas que no dependen del paciente, sino que en muchas ocasiones tienen que ver con limitaciones del sistema?
Yeah, no, it's a really good question. Let's go back. I got into doing rehabilitation in part because I went to New York City and I saw Dr. Benyushai, who has a rehabilitation program in New York City, and Dr. Leonard Dillon. And I watched what they were doing, and I was impressed that they were very practical. They never said that I can make a bad memory good, or I can reduce impaired executive functioning. They said I can help the person, I can improve their psychosocial level of functioning. I can make them more sociable in the sense of being back into society. That's what they said. So in the 80s, in 1980s, when the insurance companies were starting to pay for this, one of the appealing things for the insurance company was if you can get them back to work, I save a lot of money, and therefore I'll pay for the programs to get them back to work. In this process, though, we had to be very selective, but not, we had to, in our evaluation, determine, is it probable that this person can go back to work? If the person is so impaired that we know it's not, we would never accept them. And we would have that frank discussion with their families and with doctors and so forth. Because our credibility was that if we were having a work reentry program, we better be able to put a good portion of them back to work. So the first step was to have an honest discussion with what we could and could not do. Now, we've been fooled. Sometimes we thought people could go back to work, and sometimes we thought they couldn't, and they did. Okay? So one of the modifications that developed, and Pam Planoff does this very well now in Phoenix, they have like a 2 to 4 week trial basis where they'll work with the patients in group activities, and they start to see how they function in structured and unstructured kinds of activities, and they also get a view of how open the person is to lowering their work expectations. So we now recognize we have to go a little slower in this process before we make a decision about can you go back to work or not. Then the question is, if we think there is a probability of going back to work, at what level? And here, Dr. Benyushai was a great teacher. He is from Israel, and he has I can't imitate his accent, but it's kind of like this. He say, "Kristen, I tell you, you're a tough guy, Kristen, and you and I together, we're going to figure out, show these people that you can do better than you say you can." What he did was he became a mentor. In the Jewish, he became a mensch. He said, "I don't know what you can do, but I'm your buddy. I'm your friend. I'm going to guide you." And so with these patients, we would say, we don't know for sure if you go back to work. We think it's probable. That's why you're in this particular program. But you and I together are going to have to figure out whether that's the case. But there's a reality out there. Somebody's paying money for you to be here. So we have to see that you're making progress in order to justify this ongoing activity. Now, when you approach a patient in this manner, and they are in various forms of therapy, cognitive therapy, what we call cognitive group therapy, when they are involved in milieu therapies, where they're talking about what they've done, what they have not done, then you start to get a better picture of whether or not work is possible. And work can be defined as gainful employment, getting paid for what you do. It can be full-time, it can be part-time, or it can be voluntary. And so the process becomes one of an evolving what level of productivity will be possible for you. But the notion is we have a relationship, and I'm in your corner. I'm not going to say, I'm not here to sell you on a specific idea. We're going to figure out together what you can and cannot do. That's how we approach the process. Okay? And when that model is established, then the patient and the family, and in the United States, the insurance company, they all feel treated fairly. Because you're saying, we're going to try together to figure out how this is. This is why the therapeutic alliance is so important, the working relationship. I do think work should be the goal for many patients, but it's not the goal for all patients. But we were talking last night, if you look at this topic of resiliency that is talked about a lot in many aspects of psychology and other fields, the sense of learning something new, the ability to develop a new competency is very important for us all. And so if people cannot go back to work per se, you cannot give up on having them learn some new skill, no matter what the impairment level is. And when people develop a new skill, they say, I couldn't do that before, now I can do it. It's very invigorating. And you help the patients adjust to the brain to do more vividly. So my own personal enjoyment has been working mainly with patients to get them back to work. But I recognize there are other levels at which you can do this. But it's the honesty in the initial dialogue. We'll try, we'll see together, we're going to work and see what we can do. We'll give it a 4-week process, 8-week process, depending on where you are in terms of the recovery. And then we're going to give you our honest opinion of what would be the best program for you now. That's the way we approach it.
¿Nos queda tiempo para una pregunta? Sí.
Here in Chile, the health system is not that great. So most of the time, the responsibilities of taking care of someone who has a brain issue turns to the family. So both in kids and in grown-ups. So how do you help, or what's your experience with dealing with these families that have to have their life changed by the brain injury? And what's been your experience with these kind of families?
This is a huge problem. It's a huge problem all over the world. It's a huge problem in the United States right now. We have this on our inpatient neurorehabilitation unit at the Barrow Institute. When I came there in 1985, the average length of stay for brain injury was 6 months, and for spinal cord injury was 1 year. Now the average length of stay is 23 days. Okay, and I blame rehabilitationists for this because we didn't do our scientific homework to show who we could help over what time frame. We didn't have the data to present to insurance companies. So they're more like bankers than anything. They're going to save money wherever they can. This is a tragic situation, and I don't have an easy answer for you in terms of how to manage this situation. But I think the level of the honesty of the dialogue is very important in these early stages. And what I do and what I encourage our residents to do when they're working on an inpatient unit within a short period of time is A, don't get into a discussion that the patient and family are not ready to get into. Okay? Don't open them up and they say, oh, you have to leave, goodbye. Like you don't get into husband and wife relationships in that movie. You don't get into issues of how much recovery will you have with walking. You are respectful that they are in the early stages, and you talk with them about what can we do to make it easier for you to engage the occupational therapy? What can we do to make the transition back to home easier? We often will say to them, I know that what we're telling you is going to seem simple, but in reality it's going to be very difficult for you. It's going to be really difficult. And we want you to come back. We never let them go home without a follow-up appointment. We want you to come back after 2 weeks, 1 month. The insurance company will only authorize 6 sessions. So we're going to use those 6 sessions, and we're going to talk honestly about what's going on at 1 week after the injury, what's going on at 2 weeks, and so forth. So what you're trying to do is maintain that dialogue with the patient and the family and show an honest interest in them. And you don't always have to get paid for brief, but what I will call meaningful psychotherapeutic contacts with them. I would say to the patient, the insurance company would not pay for a 7th visit, but you know, Wednesday at 5 o'clock, I want you to call me. Just call me on the phone, tell me what's going on with John. And you talk to them for 15 minutes. You don't bill for it, but you don't lose contact with them. And you let them know, all right, and you say, well, I have so many patients, or it's impossible to do all of this. I'll be at work till 10 o'clock at night. Not so. If you have honest dialogue with them, and you maintain contact and show interest, even brief conversations, what is happening? Did you talk to your doctor about this? Let's see if we can get the insurance company to authorize 2 or more sessions. You must be willing to extend yourself so that as the problems evolve, they know there's a person there that they can talk to deal with them. That's all I can say. But it's not an easy solution. And it's, I've seen it work. I see many families get overwhelmed and angry and abusive to patients. Because I can't imagine what it must be like for them to deal with somebody that the rehab team would have a hard time dealing with, and let alone you're taking the family member and say, you take care of it. It's a great travesty. It's really something that we should be ashamed of. But until rehabilitation does their scientific homework, this will remain.
Can I say something? I was thinking that one of the consequences of the shortage in time, for rehab, and losing contact, with families and patients, is that somehow they become socially isolated. Not only the patient, but also the family, because the family changes. So that brings to my mind 2, I would say, in my opinion, relevant issues. One is that to have an awareness of the long-term needs of brain injury patients. And by long-term, I mean years and decades. I like to think that if you take a patient under your care, it's forever. Yeah?
It can be.
Yes, it can. Some of us will have the experience. So one thing is the long-term care and being clear about that. And the other thing is, how non-official types of intervention can start playing a role in the long term. I'm thinking about, for example, peer support groups, or in a way, kind of brain injury communities, which are kind of self-sustained.
Right.
Do you have any thoughts on that?
Yeah, this is a double-edged sword.
Yeah.
Support groups in some cases are very helpful, in some cases they're not. Support groups for patients with multiple sclerosis have shown to be most helpful. Why? Because the disease is a slowly progressive disease, and people have the cognitive and emotional resources to be of help. If you take patients with severe traumatic brain injury, if you put 10 of patients with severe traumatic brain injury together as a support, it's not a support, it's chaos, okay? And one person person's impulsive, another person doesn't show initiative, I don't know if it really helps. So while I think being in contact with other people that have the same health problem you do may be of value in some instances, sometimes it helps and sometimes it may hurt. But what I do think is important is that the patient and family never feel alone with the problem, that there is some resource person they can call, and it has to be an honest relationship. You can't just give them 5 hours of your time each week and not get paid for it. That can't be. But you can say, I'll speak with you 10 minutes. I'll put you in contact with this person. Call me back next Monday and let's talk about this for 10 minutes. And it's that showing an interest in them and being able to guide them at different time frames that I find very, very important. Right now, I have a patient who is a very accomplished man who has Parkinson's disease. And I've been working with he and his wife probably for about 3 years. And he's now progressed to the point he has to go into an assisted living center. And it's very interesting. Both he and his wife said, we don't want to give up the weekly psychotherapy session. If he goes into the assisted living setting, who are we going to talk to? And I said to them, look, I will call you on the phone at that particular time for a period of time. Eventually I will fill that psychotherapy session, but I will find other times to talk to you each week. And I mean that. And there have been times that I've been on vacation. And I say, and it's interesting, the patients, well, you should enjoy, you should be with your family, be on vacation. I said, it's okay. I said, 10 minutes doesn't damage my vacation. Okay? So I will call you, and I will talk with you for 10 minutes. You can't believe what that does. You're interested in them for 10 minutes. It's very, very important. And it keeps them a sense of hope. Because somebody's listening to me, somebody is interested in me, and when I'm in trouble, I know where to go to. You talk about the isolation. It's when they really don't know who do I turn to next over the problem. It becomes damage.
Última pregunta. ¿Alguien tiene una última pregunta? ¿Sí?
Please.
Sí,
Ya yo te pregunto.
las terapias de grupo, o sea, ¿cómo uno sabe qué pacientes mezclar? Porque igual es fuerte encontrarse con distintos tipos de terapia.
Yes.
O sea, vaya como, claro, como espejo, o sea, como...
Yes.
Eso, como que no les haga mal, porque se pueden asustar, o sea, hay pasado con pacientes que se asustan, ven a otro paciente que está peor y se angustian.
Yes. How would I respond to that? Yeah. Okay. Well, are there different diagnoses, like some traumatic brain injury, some stroke? Tell me a little bit. Who constitutes the groups that you're working with?
I work in a hospital with inpatients.
Yes.
And we have a lot of different types of patients.
Different diagnoses.
Yes, one was a stroke, then I was a traumatic brain injury, then I was a sclerosis, multiple sclerosis.
Oh, multiple sclerosis, okay.
It's a mix and different old.
Different ages?
Yes, different. So.
How do you work with them? So you're asking me, how do you work with them? How do you help them?
Yes, how to match them to work in a team, but they don't feel anguish because the other partner of the group is worse. So he starts to think, oh, look, maybe I am like him, and I don't know, or maybe I'm going to be like this.
I understand what you're saying. Yeah, it's an important question. See, go back to the question we had about work. When we developed our programs, we were selecting patients mainly to go back to work. And then we selected them mainly for independence in the home. So you do have to select them, that they have some communality in terms of what the goal is for their care. If you just select them because you want to help them emotionally, they can be at such different ranges that the group experience may not necessarily be that helpful. I mean, I'd have to honestly have to look at the specific patients and say, give you my opinion about why one patient would fit in versus one patient would not. But let me tell you something that goes back to our approach to patients. When we started to do group psychotherapy, I would start off with this. I would say to the patients, you know, my colleagues tell me I'm wasting my time doing group psychotherapy with you. I would tell them that. My colleagues are telling me I'm wasting my time doing group psychotherapy with you. Why is that? Well, they tell me, since your injury, you get angry quickly if I say something, so you can't benefit from keeping calm when we talk about things. Second, my colleagues tell me your brain injury affects your ability to understand what I'm saying to you. And therefore you may misinterpret what I'm saying. Right? So what are we going to do? Should we not have group psychotherapy? Or should we admit that you have problems with it? And the third one was memory. That you get upset, you don't understand, you can't remember what you're talking about. Okay? So what are we going to do? We cannot have group, or we can say, okay, let's structure this group by starting off by saying, what did we talk about last time when we met? Yesterday. So because I will help you with the memory. And I'm going to ask you to have notebooks, and when we end the group therapy session, I want you to write down, we talked about being alone. That's all, you just write that down. Let's say one other thing. What did John talk about? He talked about being alone, not having his wife. Write it down. We keep it short, but we keep the focus on to compensate. We're very early in the group experience, the value of compensating for your deficits in order to make the dialogue valuable. Now, even when that's done, and you get them saying, well, they say this is not going to help, but maybe it will. It's a very important thing to stimulate inside of them. But this was the fun part. When the patients got very quiet, like some of you are very quiet, okay, I would say to them, I tell you what, do you like music? Next week, next session, I want you to bring in a song that you like and play it in the group setting. But here's the rule. Nobody's going to psychoanalyze what you choose. So if you pick a song, you do not have to defend why you picked the song. You just play it. And we would have like 5 to 8 patients in the group. So sometimes they would forget, we'd ask their family, have them bring in the song they like. They would play the music, and what we would say is, I listen to your song, and then I'm going to tell you what it stimulates in me. I'm not going to ask you to defend why you picked that song. The music made patients alive. Just like when you listen to music on the street when you're walking. You get into it, okay? And for group to work, the patients have to feel a sense of emotional connection with the other people in the setting. So I find that without making it too intellectual, just bringing in the music sometimes would help the group solidify. And then if they have something in common, and that's why we pick them with a specific goal of going back to work, you can then begin to have dialogue that would be meaningful to them. And I remember one, I didn't bring it, but sometimes when I give lectures or workshops, I'll play it. There's a song called When Heaven Was a Drink of Wine. When Heaven Was a Drink of Wine, by Merle Haggard. I was in Oklahoma. I was with the Cowboys for a long time. I don't know if you know who Merle Haggard is, but he recently died. But he was a country western singer, and he was a tough guy. But in this song, he said, that psychoed out psychologist asked me about my drinking ways. You understand that? About my English, for those of you, I don't know if you can say it in Spanish, but that psychoed out psychologist asked me about my drinking ways. But if the truth were known, I never took a drink until she was gone. Okay? We played this music, and the Cowboys, they were cowboys and oil field workers. They laughed. They roared. They said, you're not just an intellectual PhD. You're a real guy. And then we started to talk. If the patients see you here or different from them, it's so much more difficult. But the music is a great communality. It allows them to experience you human. This goes back to what Carl Rogers told me. Hope it doesn't take you too long to get past your PhD. Okay? But when you bring in the music in a group setting, and if they're at an appropriate level, it's an amazing thing. And then they start talking about what's really relevant. And that's how it should be. Go back to Eric Erickson. Do they talk more about something that is important to them? If they do, you're on the right track. If they do not talk more, then you're on the wrong track. You have to pull back and say, what am I doing here? You know, how do I modify this for these patients? It's a long-winded response to you, but that's, if I could see the patients and see what you're doing, then it would be more practical. Then I could give you specifics of what would make sense to me and what would not make sense to me. Okay? But I'm glad you asked the question. I think group work is very important, but it has to be done in the right way for the patients to really benefit.
Well, you don't have to leave it here.
Okay.
We thank you for your time, for your thoughts and your willingness to share, your experience and your pearls of wisdom, as they say. We will continue this conversation later on. At 2, we're going to meet here in the same room, but to discuss more specifically 2 papers that you wrote a while ago.
Yes.
Which some of them, they touch some of the topics that we're being kind of discussing. So I just want to thank you and thank you everyone for coming and participating in this.
Before you shut it off, I want to thank Christian for asking me to come here. You know, you have a talented guy here, and I really have enjoyed interacting with you. And we wrote a chapter together that we've had a lot of fun doing. So it's my pleasure, and I thank you for inviting me to come.
You're welcome.